So we're going to start off by taking vitals. My voice just cracked, I apologize. Vitals are really important to take in patients that are pregnant and pelvic health patients in general, because obviously you want to monitor your vitals with all patients, but your vitals can vary significantly during pregnancy for a variety of reasons. So we want to keep that in mind. I'm going to stop talking for a second so I don't go deaf. Here. Just in there. So I got 126/72, which is awesome. And that'll keep us within normal range for exercise. You want to make sure that your patients that are pregnant keep a blood pressure that's under 140/90, just so that way they are safe. Blood pressure is expected to go down throughout pregnancy due to the increased demands, and you gotta have that extra blood flow for the baby. But there are cases of gestational hypertension that can occur, or preeclampsia as well, so it's definitely something to monitor, especially towards the later stages of pregnancy. On top of that, blood pressure can also be affected by the hormones like relaxin, which is a vasodilator as well. So, on top of that, we're going to be looking for heart rate and respiratory rate. Respiratory rate and heart rate both go up throughout pregnancy. Heart rate goes up due to all the increased demands and that need for more blood flow, and the respiratory rate can go up due to the rib flare, due to the increased baby size, causing issues with the ribs and this ability to expand, leading to hyperventilation. So we have pulse ox here, making sure that she's in normal ranges, and we'll also look at her pulse ox to make sure there's enough oxygen for both the mother and the child. She's within normal limits, no concerns there. You can also take it manually using the radial pulse, and we want to make sure that we monitor it throughout exercise so that way we don't have any issues. So next we're going to assess gait. So for gait, we're looking at a lot of different things. We're looking at assessing arm swing, stride length, if they have any losses in balance, their base of support, see whether it's wide or narrow, and where their center of gravity is. So if they're leaned forward or leaned back, things like that. In pregnant patients, typically they have a wider base of support, and their center of gravity is shifted more anteriorly and superiorly, which puts them at a higher fall risk. So you might see that they lose their balance, or you'll see that they kind of have like a waddling gait because their base of support is wider. So we're going to have Katie walk. So you'll notice with Katie as she's walking, if you can see it over the camera, I apologize for the quality, but you'll see she has a pretty decreased toe out, so her toes are pretty straight, almost like she's walking on a tightrope. She has pretty significant femoral anteversion on both legs, which we'll talk about later, but you can kind of see that in her knees as she walks. You can also see that she has a little bit of a hip drop when she's in stance phase on her left leg. So if you look at her right hip, it kind of goes down as she's standing on that left leg. It'll kind of tip a little bit. But her arm swing is normal. She has a pretty decent stride length. So she's not, waddling like a penguin with really close steps. She's got a pretty good gait pattern, no losses of balance, and her center of gravity is where it should be. So now that we've assessed gait, we're going to further assess balance since she's already up and standing. We're going to use Romberg, sharpened Romberg, and a single leg stance. So we're going to start by having her put her feet together and having her eyes open for 30 seconds. We'll fast forward so that way you're not standing there watching her stand for 30 seconds. So next, as long as there's no loss of balance, is here. She's going to close her eyes. Do the same thing for 30 seconds. I'm making sure that she's not falling. We got a gait belt on her. And then after that, we'll do sharpened romper. So she's going to stand in a tandem stance with one foot in front of the other like she's on a tightrope. She's going to do that with her eyes open for another 30 seconds. And then if there's no issues there, we'll do eyes closed. And then last but not least, once we've survived that with no losses of balance, then we'll try a single leg stance. Single leg stance is super important because it's a very large majority of the gait cycle, so we want to make sure that she can handle that so that way she's safe for gait. And then we can also try that with eyes closed. There we go. A little bit of weight shift in there, but we're handling it pretty good. All right, awesome. We can also try that on the other leg as well. But for time's sake, we'll let that go. So next, we're going to assess posture and evaluate some landmarks. We like to do a bottom-up approach. We're going to start anteriorly. So I'm going to assess her feet to see kind of where they're positioned, see if they're really close together and she has a narrow base of support, or if she has toe out, you can look at her arches, stick a finger underneath. Her right arch is a little bit lower than her left. Then we'll go up to her knees. As we had talked about in previous videos, Katie has pretty significant femoral anteversion, which means that her femur is kind of rotated. It's much more significant on the left, as you can see anteriorly. So I can palpate the orientation of her patellas and her femoral condyles to get an idea of where that's sitting. From here, I'm going to move the camera up. If my computer wants to cooperate. All right. So from here, we're going to assess greater trochanters bilaterally. See if there's a difference in height. From there, go a little bit further, assess ASISs, which look pretty even. Get an idea for iliac crest as well in the front. Beautiful. Work up a little bit more. We can also just get a general assessment for where her shoulders are sitting to see where we're at, see if she's tilted or any signs for scoliosis. And you can also look at the width in between their arms and their trunk as well. So it's a little bit decreased on her right side. From there, I'm going to have her turn around and look from the back. Start from the bottom once again. So here we can look at the calcaneus to get an orientation for inversion or eversion, kind of see where that arch difference is coming from. Also look at the orientation of the Achilles tendon. Then we'll go up to the popliteal fossa to get an idea, look again at that anteversion. From there, move the camera up. We'll go back to the iliac crest, find those PSISs, and then from there, assess gluteal folds. We're a little bit lower on our right side, so that gives you an idea of tones for the gluteal muscles. Then from there, move the camera up once again. We'll get an idea if there's any signs of scoliosis. Look at that arm length again from the back, and we'll also look at the inferior angles of the scapula. So see if there's any issues there. From there, I'm going to have her turn laterally, and we'll get an assessment for the plumb line. Not going to move the camera for this one, but basically getting an idea from the ear to the shoulder to the greater trochanter down to the lateral malleolus, an idea of where she's sitting. Her hips are a little bit farther forward, but ideally they should all be aligned in a straight line. So from here you can see forward head posture, which is very common amongst all college students, so we almost all have a little bit of that. I can also part her hair so I can see her ears a little bit easier. And that's about that. So she's sitting a little bit with her hips a little bit farther forward, and she's got a little bit of forward head posture. And that's where we're looking. We can also get a bit of an idea of her kyphosis and lordosis from this position. And from the side, you can also look at the ASISs and PSISs to get an idea of what kind of anterior tilt she has. So normally somewhere between 10 and 20 degrees, which is about where she's sitting. So it's a good sign.